Hello, everyone. My name is Chris Ma. I'm a gastroenterologist at the University of Calgary. And on behalf of my co-authors and the senior author, Dr. Iko Hirano, it gives me great pleasure to share our recent paper in gastrointestinal endoscopy entitled Reliability and Responsiveness of Endoscopic Disease Activity Assessment in Eosinophilic Esophagitis. EOE is an increasingly prevalent chronic inflammatory disease of the esophagus, and there's tremendous interest in developing novel pharmacotherapies for patients with EOE. Endoscopy is a useful tool for assessing disease activity, and it's also a prerequisite for collecting esophageal biopsies for histopathology. However, validation of an endoscopic instrument for use in EOE RCTs is a research priority. Previously, Hirano and colleagues had developed the EOE Endoscopic Reference Score, or EREFS, and several trials have used the EREFS as a secondary endpoint. However, there was a lack of consensus on the most appropriate methods for scoring the EREFS. For example, it was unclear whether different components should be scored in different segments separately, or whether individual components should be summed or weighted. Finally, for use in an RCT setting, identifying the most reliable and responsive endoscopic features is critical to ensure that the endpoint is sensitive and discriminates change. Therefore, we conducted a multiple phase study to systematically evaluate the performance of endoscopic evaluation in EOE RCTs. First, we used a modified research and development University of California, Los Angeles appropriateness methodology to identify endoscopic items that are appropriate for inclusion in an endoscopic score. We included 15 international EOE experts, both from adult and pediatric practices, all of whom had extensive experience in EOE disease assessment. And this panel anonymously rated 41 different statements pertaining to existing items and indices, item definitions, item level grading, location of disease assessment, and other endoscopic considerations, using a 1 to 9 point Likert scale based on appropriateness. We went through 2 rounds of anonymous voting and feedback, and then took potentially appropriate items into the next phase of the study. In the second part of the study, we used clinical data and endoscopic videos that were collected from 2 prospective clinical studies conducted at Northwestern University and Amsterdam Medical Center. These studies included adult patients with EOE treated with swallowed topical corticosteroids or elimination diet, who had video recorded endoscopies both before and after treatment. All of the videos were evaluated in duplicate and random order by 2 EOE expert gastroenterologists. And these central readers scored both the original EREFS as well as different modifications of the EREFS, which were derived from potentially appropriate items in the RAM process. Using these reads, we calculated the inter-rater reliability between readers and the intra-rater reliability within the same reader. We then calculated responsiveness of the EREFS and its different modifications. This was expressed both using the standardized effect size as well as non-parametrically using the probability for distinguishing patients with and those without improvement, quantified as the area under the receiver operator curve. In this study, we considered several modifications of the EREFS. These are summarized in Table 2. The key features of the EREFS, including exudates, rings, edema, furrows, and strictures, were considered both in a simplified fashion as either absent or present, as well as in 2 expanded versions of the EREFS with more grades for exudates, edema, and furrows to see if we could better capture the dynamic range of the disease. We also considered scoring the EREFS in the worst possible disease location based on the most severely active endoscopic area, as well as in separate locations in the esophagus, separated as GE junction, proximal, and distal esophagus. Finally, we considered both an inflammatory and fibrostenotic subscore. There were several key findings to our study. First, the EREFS, as well as its different modifications, were very reliably scored. There's moderate to substantial inter-rater reliability, for all of the versions of the EREFs. Additionally, we found that the most reliably scored item was esophageal rings, but the least reliably scored item were esophageal strictures. This is unsurprising given that stricture assessment is often as much based on tactile feel as it is based on visual assessment. And it's similar to what we've previously observed in patients with Crohn's disease. Second, we found a significant degree of responsiveness to the modifications of the EREFs and the original EREF score. Numerically, the expanded EREFs was the most responsive. Additionally, when we scored the EREFs in the worst affected area, we demonstrated the highest numerical responsiveness. The inflammatory subscore was numerically more responsive than the fibrostenotic subscore, recognizing that the therapies we included in this study in terms of elimination diet and swallow topical corticosteroids both target inflammatory disease. Our study has several important implications. First, in the RCT setting, our study gives confidence to the ability for central readers to evaluate endoscopic outcomes, which reduces the risk of observation bias. Second, we provide clarity on how the EREF should be applied. Responsiveness is maximized when the worst affected area is scored, and we do not lose reliability with an expanded EREFs as compared to a simplified EREFs. We also highlight several areas of additional research. First, our results are not generalizable to pediatric patients who represent both a population with significant unmet medical needs, as well as a population with potentially a different endoscopic appearance compared to adults. Finally, the performance of the EREFs in therapies targeting different mechanisms of action will be required to get a more complete picture of its operating properties, particularly in response to therapies targeting fibrostenosis. On behalf of my co-authors, we want to thank you very much, and we hope you enjoy reading the manuscript. Thank you.